know there's some individuals that couldn't join today, and we will be recording today's Swingbed webinar presentation, and we'll send out the webinar link when it's received so that you can share with others. And want to make sure and thank Joyce Fillenworth and David Conrad at the State Office of Rural Health for providing the support to be able to offer you the swingbed education, and also to thank Allie Orwig and Indiana Rural Health Association for supporting Zoom. I do want to share that we sent out to the primary contacts last week a 2020 rural crosswalk that outlines many of the flexibilities that CMS has provided. This is a CMS document, but it's the flexibilities around COVID-19. So when we forward the recording and the handouts from today after this session, I'll make sure and include the link that outlines all of those flexibilities for the rural area around COVID. Not only includes the flexibilities for critical access hospitals, but the SNFs and FQNC. So this time we'll go ahead and introduce Kerry Dunning and turn the presentation over to her. I believe most of you know Kerry. She's been working with us for a long time, about 2.5 years now, and providing swingbed education and helping with quality improvement, meeting all of the requirements, and just a lot of good general knowledge about having a solid swingbed program. So Kerry, I'll go ahead and turn it over to you.
Thanks, Becky. I really appreciate it. I'm going to be very happy for the day that the lead-off topics do not have COVID somewhere in the verbiage on the slide. I know all of us are getting tired of it. I actually had gone looking and had intended to do some more creative things, but as Becky just said, in the last 2 weeks, CMS has been dropping document after document after document on COVID. And by the way, if you have not downloaded that brochure that Becky talked about that she provided you last week, it really is a great synopsis of everything that, if you're like me at all, we've been digging through pieces of paper and, you know, the quality sources and CMS and CDC trying to find it. The one reminder I'll put on it right now, because we just don't know, is we are under a public health emergency, at least I think it's through the 3rd week in October. For it to be extended at that point, Alex Azar will have to sign a new one for a new 90 days. So we'll see as that comes up. I will tell you that many of us believe, with absolutely no proof, but believe that some of the things that have come out of this, for instance, the use of telemedicine, will be extended into the skilled rules permanently. We don't know what version yet. So we've got more of this sort of immediate emergency to get through. And then we have an interim time period where it's going to be really interesting to see what we get, what we don't get, what we're going to fight for, you know, all sorts of things that are going to be happening. So I think we're in for sort of a roller coaster ride. And at the last part of what I'm going to talk about today, we'll go back to some basics that, regardless of what we're in, we need to be paying attention to. So I have included handouts, and the first 3 have come out in the last week, and they're talking an awful lot about focus surveys for nursing homes. There is a focus survey protocol handout, and what I found interesting in it is it lays out exactly what the surveyors are supposed to look for. Now, I know all of this says nursing homes on it, and I'm going to tell you one variation from nursing homes. It's very clear-cut in a second. The rest of it, we have to lean on what they're sending out for nursing homes, because they could be CMS surveyors, they could be state surveyors coming in to do focus surveys. All the nursing homes in Indiana, as well as all the other states, have been surveyed at least once. I have several clients that have now been surveyed 3 times in 4 different states, so that means multiple states are doing it, for the infection prevention. So that's going to be a hot list topic. And on that first document, the focus survey protocol, there is I think it's on page 3 of the document, there is a list of things that surveyors are supposed to do when they're on site, which is why I like for you to have this document, because it gives you a heads up about things they will ask for. And I'm going to point out, and it seems I'm really kind of surprised about this, but the top violation across all the nursing homes, which are about 16,000 of them in this country, that they had from the infection prevention mandated survey was hand hygiene practices. Now, you consider that and the fact that probably 90% of the surveys were done virtually. That's even scarier to me, that they virtually found hand hygiene practices to be the major problem across the country. And second to that was the proper use and discarding of PPE. In nursing homes, that's probably due to a lot of CNAs trying to do things quickly between rooms. Gloves, as you know, we've talked about it, and you already know, trying to get gloves off without contaminating your wrist or a hand can be difficult. So I'm going to keep to my suggestion here that you should be doing ongoing, rotating through every couple of weeks, every month, whatever you're comfortable with your own staff, making sure that we have on record the training that we're doing ongoing as far as the use of PPE and hand hygiene. The third one was cleansing medical equipment as far as violations that they found. I actually have an experience with that in a doctor's office where I had my blood pressure taken, cuff and machine, didn't think anything about it, and the nurse came back in and got it, said I needed it for another patient, rolled it out, and I realized she hadn't cleaned it before she used it with me, and she didn't clean it before she left the room with it. So there's things that we just forget. I had a friend that works in healthcare that yesterday walked into the hospital and forgot to bring her mask out of the car. I mean, you just fall back into habits, or maybe what we wish could happen. So, and the fourth thing that they're looking for is the effective transmission-based precautions, which gets into signage and screenings and all sorts of things. So that document, I think, will help you, because that's exactly what the surveyors are supposed to ask you if they walk in. The next one is the interim guidance for the antigen testing, the rapid antigen testing. It's a CDC document. I'm not going to go through that, but they have very good definitions. And beginning on page 5 of that document, they have testing strategies for each of the types of situations we might run into for diagnostic, screening, and surveillance. It's a nice grid that may help your team kind of follow through that a little easier. And then the other thing that came out actually on August 26th was another QSO. And if you don't remember the QSO, the Q and S are quality and survey. So this is a documentation that they put out routinely. And you'll see at the end, the NH is for nursing homes. And so 20 is year 2020, 38. This is the 38th document they've put out this year for nursing homes. Much of this starting on March 8th is the first one. So from March 8th to today, we've had 38 just for nursing homes. And if you have rural health clinics and you have your hospital and you have professional offices, there's a list that deep for everything right now. You will not be surveyed as a nursing home, but again, it's a reminder of what is going on and how they're going to be looking at policies, revisions that they've had in regulation, how you've adjusted to that. Certainly the facility testing and those things that I just talked about, the hand hygiene, will be high on that list. What's important in this document is at the very end, they have a focus survey document for infection control that the surveyors will use to judge the nursing homes. It's another good training tool that you can use. What's also maybe important in that, I know you're not into the F-tags, but you can be surveyed. You can be assigned an F-tag, which is a federal tag denoting a deficit that can lead to fines. They have not done as much critical access swing bed surveys in the past. They had started about a year ago in multiple states, increasing them. But because of this one being infection prevention, you're more likely to run into that. And when you first read it, at the top of that infection control focus survey, there'll be 2 F tags in red, and that's because they're brand new. So they're now actually 6 tags. Federal surveyors can only give several of them, but 6 tags that you can get out of a focus survey for infection prevention. So, or in this case, infection control. So please at least glance through it and look at those last pages. The thing that I do want to remind you, unless it's different in Indiana, and I hope you know me well enough to know that I default to state rules, and if we need to get a ruling on it, then that's the value of having Becky on this team and listening in, and certainly the State Office of Rural Health. Normally what's going on now is that instead of meeting a separate requirement for nursing homes on the patient testing, which is pretty involved, you are falling under hospital guidelines because you have to report all your patient numbers, and it really doesn't make much sense to separate out swing beds in a critical access setting from those hospital numbers. But first, you want to make sure that that's the way it's getting reported. I'm going to reverse that. First, you want to make sure that's how Indiana wants it. And second, you want to make sure that's how you are reporting it. Remember, nursing homes, we've got long-term care residents, and there are different times that people are being infected, and you obviously know the statistics about nursing homes. So those are some pretty heavy-duty requirements. The one item that you probably want to test and pay attention to as far as surveillance will be anyone that's coming from another facility. How you do that will be set up by your criteria and your policy on that. So just make sure that you have a clear-cut policy that's up to date with whatever is going on currently. I know we're beginning to get hot spots again. My home state of Missouri is really getting it again. Some of the Iowa, other Midwest states are getting hit hard. We'll see after Labor Day weekend if Florida hits the bad list again. But we're going to be in and out of this for a while until we figure out how to slow it up, stop it, vaccinate it, whatever the combination may be. So check with your hospital on that. And then one other handout that I have is a CMS data update that was released on September 3rd, which is really kind of interesting, and I've included that in your handouts. But I want to hone in on one thing in there, which is on the discharge status and length of stay for COVID hospitalizations. 29% of the beneficiaries, this is Medicare data, beneficiaries went home at the end of their hospital stay, and 24% died. So if you do the math, that's about half, a little over half, either went home or died. That means the other half needed other Medicare services. And that is where we're finding the swing beds and critical access across the country are really picking up the slack as nursing homes have closed admissions or closed and then open and maybe closing again. That's going to be on again, off again, probably through and into the spring anyway, and probably through the spring from what I'm hearing. So this is a time where I'm going to remind you that you have an opportunity to determine if you are going to be a hybrid and take COVID and what we will now start calling the regular swing bed patient, those that had wound care, IV antibiotics, and post-surgery that needed ortho and wound care, et cetera, surgical wound care. Or if you're going to do all COVID or all non-COVID, and obviously that's going to switch around depending on what's going on in your neck of the woods. But you have a time here to declare really what kinds of patients you want to take. And second, this is a time for you to be extending your referral hospital outlook if you want more swing bed patients. Because as the COVID patients fill up the hospitals as we hit these hot spots, they need a place to discharge patients, and critical access swing bed can cover the cost better than most of the PPS swing bed programs. So it's time for you to sit down and say, you know, what are our expectations here and what are we going to be doing for the next 3 to 6 months as far as how we want our swing bed program to look. Of those, nearly one half the hospitalizations lasted 7 days, and then just under 5% lasted more than 31 days, and that's just the acute stage. You know, anybody 31 days in acute has got post-acute coming, and even some of the hospitalizations, though I have not seen a breakdown on it yet, most of the Medicare population that was hospitalized for COVID is getting some kind of post-acute care, either in the home or in a skilled setting. So a lot of opportunity there. It's kind of an interesting document, and there's a lot of graphs that might be interesting to you. All right, so the last part that I want to do and see if you have any questions is some reminders of our real life. We were to move away from the ADL language this October. Those that have to complete an MDS, which is not your swing bed setting, but PPS swing beds and all the nursing homes, we're moving to a new MDS that was getting rid of ADL language. Obviously, with COVID hitting, CMS is out of whack, everybody else is out of whack, and they postponed that. They recently updated the MDS to version 1.17.2. I've always suggested you use that as a training tool for your own staff so that you know what to document, what CMS is looking for in documenting a skilled stay. So that 0.2, the 17.2 would be the version that you would like now. And the plan was to move totally to functional game language. On the MDS, ADL were section G, and functional game language is section GG. I would suggest that you start looking at functional game language and start switching your documentation toward that language. It is a coordination between nursing and therapy more so than it's been in the past. And I think it would be very helpful for you now that we know that you're going to have probably at least a year, maybe a little longer, how things fall out, to make this change as far as your EMRs and that work that has to be done behind that. But it's a good starting point for 24-hour nursing and skilled therapy to start talking about what the patient needs in terms of how they were functioning when they came in the program, what the goal was, and what was their ability when they discharged. This is what Medicare is tracking. They want to know exactly what they were capable of doing when they come in, and they want you to set a reasonable goal. And at the end, they want to know if you met that goal. In other words, Medicare is saying, are we getting our money's worth if they're having to complete the MDS? Now, you don't have to complete the MDS, but guess what? A surveyor, and in this case, an auditor, will be looking at, you know, if you have people coming in, you keep them 7, 8 days, and they're not making progress, Medicare is going to start questioning what they're paying for. So I would look at the functional gain language and see what you can do to start moving towards it. You have a kind of a comfortable time period now to do that. We don't always have that, so take advantage of it. Activities is really highlighted at this point on surveys and discussion by CMS. We've got an awful lot of people in isolation, and I will tell you, I started 3 months ago, and now I'm hearing some of the statistics that we're going to have failure to thrive as increasing number of deaths in nursing homes because people have been isolated. They can't even see their families unless nursing homes are capable of doing some very creative things as far as window parties and all that sort of thing. So Zoom helps, but it doesn't always substitute for seeing somebody in person. So if you remember, you are still to be doing activities and an activities assessment. It doesn't have to be where you have the activities director or coordinator anymore. But that means we need to make sure they have things in their room, whether it's television, crossword puzzles, whether it's phone calls, whether it's Zoom, whatever we have, and that you are documenting that's what's going on and documenting what that particular patient needs, individualized care. And then the other thing I think is going to be increasingly important. You heard the numbers of people going home directly were very few from COVID stays with the Medicare population. The follow-up after discharge, I think, is going to be more and more important. We've talked about it from a marketing standpoint. We've talked about it from a tracking standpoint to avoid the rehospitalization penalties that your referring hospitals would be paying if they came back within 30 days. Now I think it's a lifeline. You remember, within 30 days, if somebody is not doing well, and that's medically, but if they're not doing well, they can still come back into your program within 30 days. And I'm going to say without a hospital stay, because that's sort of the way the language is written, even though we're bypassing the 3-day stay. In other words, they still had to be sick enough to be at a skilled level, and they have to meet skilled criteria, but they can come back in. So it's a good way to stay in touch with people. It's a good way to make sure that if you have set up doctor's appointments for them, that they're keeping them, so that we can help people get through this. So with that, Becky, I think I'm going to stop and see if people have questions today.
Yes, Kerry, could you cover again exactly where you find that functional gain language information?
Yes. So it is MDS 1.17.2. And you can get that on the CMS website. You just, in fact, never mind, Becky, I'll send you, send you the MDS.
I was going to say, when we...
Yeah, never mind.
Yeah,
I'm going to tell people to do it, but that's all right. I'll find it. I've got it.
Yeah, I was going to say, we can send out the link to that when we send out the recording.
Yeah.
Kerry, also, okay, I will remind everyone, just open up your chat any struggles that you've been having or any questions. And while you're doing that, and we did just have another question come in, do we still have current waivers for ability to go over 25 inpatient beds? If so, until when?
Yes, that is tied very specifically to what they call the Public Health Emergency Documentation. It's PHE shortened, if you see that in writing. That's the document that Alex Azar, who's the Secretary of, Health and Human Services at the federal level, signed on July 23rd or 24th. And that gave us 90 more days of a public health emergency. That's why I'm saying by the third week, I keep saying I got to count out 90 days, but somewhere by the third week in October, those 90 days will be up, and we will have to have him re-sign a public health emergency declaration, and that will be good for another 90 days. And it will keep going like that until one is not re-signed, and that's usually when it is deemed that it is not at an emergency level. We live with flu bugs and pandemics past emergencies. It's just a matter of right now with everybody, their whole lives being tied up in this. So your current waivers allow you to go over the 25 beds if necessary. It gives you what the language that you will see is called hospital without walls. It gives you, the ability to use non-hospital bed rooms for putting extra people in your facility. So you can see that language. And this is all good up until that last part of October.
And some of you had joined after we had shared, and this particular language around the flexibility to go above 25 inpatient beds is also listed in the CMS document 2020 Rural Crosswalk, which outlines all the flexibilities for all the rural providers. And it does do a very nice job of indicating exactly which provider setting each flexibility falls under. And also included in those flexibilities are the waiver on the length of stay as well.
Yep.
Kerry, I also thought this might be a good time for you to cover making sure that you have a good contact with the MAC and the regional office.
Yeah. Yes, there's a couple of things going on that we need good contacts with right now and to build the relationships. But one of the things that MACs will do periodically is we'll get a directive from CMS and a MAC will translate it differently. And that may mean you're getting paid the amount you expected. It may mean that you're getting a deviation from the amount that you expected. And this can be acute as well as swing bed, any of those settings. And normally when that occurs, that's when we start contacting the MAC first, but also can get in touch with your Medicare regional office, which I think for you guys is Chicago, and saying this is what we expected for reimbursement. And this is what we expected to be reimbursed for, but our MAC is saying we're not reimbursing for that, or this is the rate that we're giving you, and so forth and so on. So it is your business office hopefully has a relationship with somebody at the MAC, as well as the multitude of insurance products that are out there now, whether it's, you know, Humana or I don't know who you have in your state, but we certainly have Blue Cross Blue Shield and so forth across the country. But you're going to have more and more the relationships with the regional CMS office and your regional MAC to go forward. And it's not just for this, whatever we're going to have a year or so, maybe more of COVID. I've said before, we've had 13 pandemics since 2000. We have lots of unusual things hitting us pretty routinely now. And the best way to meander through those appropriately is build a good partner in both of those offices.
And Kerry, if you could kind of explain to everyone, not everyone may be familiar with what a MAC is.
Okay. The MAC is the Medicare Administrative Contractor. It is what we call a fiscal intermediary. They are the arm of CMS. They are separate. They're contracts, but they're charged with paying you. You submit, you meaning the hospital submits a claim, let's say for a swing bed stay. It's if you were in Indianapolis when we had our live get together, I actually asked you to bring in a copy of the UBO4. I think it's a really good time for your team once in a while, maybe it's once a month, maybe it's once every 6 weeks, to take a closed chart, get a detailed bill and the UBO4 and start looking at them. They have to connect. Those dots have to connect. What's on that bill comes from your documentation, literally. And so if we're not getting it documented, if we're not getting things to the bill correctly, and if the bill doesn't reflect things correctly, for instance, if somebody had 3 lab tests in the day that they went from acute to swing, you know, which lab should be on which claim? Those are the things that sound small, but they can build up. And I'm telling you, your billing department works pretty hard at getting through all that, but they don't know everything that goes on in swing particular. That's where that teamwork comes together. So the MAC is the guy, the group of people that are supposed to be paying you properly for the services you provided to Medicare residents. Medicaid will also go through MAC, and then your insurances, and each insurance contract has different components to it. And that's where your business office has to work very, very hard at keeping them all up to date and keeping them separated to understand what is covered, what's not covered under each one of those programs.
And I would also say when we reach out to the state regarding most reimbursement issues, they have often referred us and had hospitals connect with their local MAC contact. So
it's going to be a way.
Any other? Yes, I agree. Any other questions or concerns that individuals have? I know there, Kerry, something that you may cover that kind of falls underneath reaching out to your MAC is if you could cover again for us if a patient has an appointment during their swing bed stay,
yep.
Making sure that transportation is covered. That question's come up a couple of different times here in the last month.
Yeah, so the only thing I can say to you, because I wouldn't swear on a stack of Bibles on anything, because CMS, while I'm talking to you, is probably changing something. But it's been very clear for about a year and a half that critical access swing beds, the language is that anything provided to a swing bed patient while they're in your program has to be billed on the swing bed claim. That's anything and everything. It's come up an awful lot with dialysis. That dialysis centers cannot bill, or a dialysis outpatient cannot bill Medicare separately, but they have to bill you have to put it on your swing bed claim, and then you have to get reimbursed from CMS for that. There's a huge financial risk in that your CFOs, I'm sure, I hope, are aware of now, and certainly are trying to balance out how to do things like that. Even before COVID, there were only a couple of things where transportation was paid for separately, like getting somebody, you know, well, I'm trying to think. So, dialysis is a good example. For the PPS hospitals, dialysis was not only separated, this is PPS now, not you, but so was the transportation or the ambulance fee. So there have been some things, but in your setting, it's everything is included. Now, that's one statement. The second statement that has always been in place is there's an expectation that if somebody is supposed to see their primary doctor during the week when you may have them, or if they're supposed to see their dentist, when they come in, you're supposed to ask the families to postpone an appointment like that we would consider standard. In your case, as the provider, if somebody needs to go back and see their orthopedic surgeon because of post-surgery, that's an expectation as part of the care that you're providing to make sure the hip really is in place, et cetera. Then you would be paying for the transportation for that. But I hear too many times that you guys have worked very hard to keep appointments. And the point is, if they're sick enough to be ahead in the bed, then they don't need to be going to what were normally scheduled appointments. So there's two sides of that, to make sure that you are controlling the costs appropriately by not sending them out to things they don't need to be doing while they're a patient in your swing bed program, and understanding that anything you are ordering is going to end up on that claim. Ultimately, can be cost report settled, but that's not done on a month-to-month basis, and some of those expenses can really hurt a small hospital significantly.
Correct. And when we have reached out to individuals or the state regarding those questions, they have always directed us that the critical access hospital should contact their MAC for clarification. So.
Yeah.
Well, that draws us to a conclusion to today's program. As you're working through issues or you have any questions regarding any of the waivers, reach out to us and we will send you a link to today's recording along with the link to that rural crosswalk for CMS flexibilities and all of the associated handouts to support the information that Kerry's provided today. So stay safe. Again, keep sending us your questions and concerns, and we'll do what we can to get some answers for you. Thank you so much, Kerry. I really appreciate it. Goodbye, everybody.